tomorrow. Okay, great. It's still not advancing. It's not intuitive. Thank you. So our proceedings today, at least the lecture portion, will be webcast. We've had such an overwhelming response to holding the workshop, and we had a restriction on the number of people we could fit in the room. So the webcast will be available about 2 months after today, and here is the address. And we did not print slides in favor of protecting our climate and not wasting paper. So make a note here that the slides are available on this website right now. So our first speaker is our Division Director, Dr. Robert Coyle, and it gives me great pleasure to have him kick off the meeting and welcome everybody. Dr. Croyle's been our director since 2003, and he also serves as the director for the NCI Global Health. And prior to that, he was the acting director, he was the associate director for the Behavioral Research Program. He is a professor of psychology and a member of the Huntsman Cancer Institute at the University of Chicago prior to joining NCI. Dr. Croyle.
University of Utah, Huntsman Cancer Institute, and Fred Hutch before that. Good morning, everybody. So a lot of you have been asking when we were planning this meeting, there are a lot of meetings related to this topic: Academy Health, PCORI, ASCO Quality Forum, HRQ meetings, et cetera, our own implementation science meetings, health services research outcomes meetings. Some of you have been to ISAQUAL, some of you attend, a lot of these meetings. And so I wanted to just kind of mention that put this in the context of all these other things are happening. And so when we did this meeting, and Paul and I were talking, Dory Rose and I were talking earlier, you never quite know within the context of these things, is there still a need for something more or beyond all of those? We know a lot of you attend a lot of other meetings or are part of networks and consortia and initiatives as well. So this meeting is really kind of a culmination of our decision a few years ago to reorganize our division of NCI and create a newly formed, larger healthcare delivery research program, recruit Paul Jacobson as Associate Director, so stole away from Moffitt Cancer Center to lead this effort. And our leadership group within Healthcare Delivery Research Program was reformed around this theme. And so both in part as our responsibility in being NIH's largest institute, and also the fact that we support the NIH's largest national research infrastructure, whether it's the 71 cancer centers, the SEER program, all of our numerous epidemiological cohorts, research consortia initiatives, and then now with all the newly launched initiatives from the Cancer Moonshot. We were just counting up the other day in terms of just the moonshot-related initiatives, and we've now obligated over $300 million of your tax dollars just on cancer control and population science initiatives from the Moonshot funds. We thought it still made sense to pull together a cancer meeting that was interdisciplinary, and there's many people in this room that you know and some that you don't know because of their different affiliations, their different levels of analysis, whether or not some of you usually are at all the meetings related to measurement, some of you are more non-cancer specific, and you at meetings on hierarchical analysis and multi-level analysis. Some of you are more organizational in terms of your focus and expertise. Some of you would label yourself as traditional health services researchers. Others of you maybe label yourself as a cancer control researcher. And we could rattle off many, many other areas. But we thought having all of you here together at one place and one time in a focused discussion about where things stand now and where we should go next made sense. So clearly we recognize that there's components of the meeting today that are similar to one other meeting out there that you may have attended or may be attending in the coming year, but pulling all these pieces together in this one focused discussion will be especially helpful to us as we look across the healthcare delivery program and think about new directions and next steps. The other thing too is that in this, as we've been growing this area and funding more grants, whether it's in health economics or outcomes research or measurement and assessment, all the different areas that you all work in, and then connect to other organizations, additional disciplines, and again, try to merge the cancer-specific world that you see at kind of the different ASCO-sponsored organizations, the non-cancer specific world of other funders, whether it's PCORI or ACS or HRQ or many others, Robert Wood Johnson, et cetera. Having a focused meeting around this set of issues that's outlined in this program. At the same time, one of the things we felt that there was a lot of work going on outside the cancer domain that's not fully integrated within the cancer work that we see and that we support, whether it's methodological advances or use of measurement tools or ways of analyzing data, particularly in multi-level analysis. Having this focused effort together in this way, we think is going to be a value add beyond all the other meetings that you all attend. So given that many of you involved in many of the things, thanks for being here. Again, when put something like this together, you never quite know what to expect. And so we do apologize for those online. Those will be looking at slides later because there was a lot more interest in being here in person than we were able to accommodate. The larger room down the hall is the room where we hold our monthly division all staff meetings, which starts at 9:30, so I'll be running off to that. So literally we were constrained by the size of the room. What we really hope in terms of driving out of this meeting is a little bit of both a look back and a look forward. But also, as you sit through the meeting, what would really be helpful to me and members of our leadership is if you think that we are missing, or your colleagues, or the portfolio, the research that we've been funding is missing the connections across levels of analysis, the connections across disciplines, and also the connections between those who really focus on evaluation and assessment and measuring organizational variables and processes, and work in those areas which goes across a lot of diseases and a lot of contexts, to which some of that work is not yet being brought to bear in the cancer domain. So appreciate your taking time to be here. Appreciate those who traveled far, because I know many of you did. Look forward to all recommendations. Please, everybody, I want to encourage everybody to speak up and participate in those breakout groups that we'll have later. So I know some of you are here to listen and learn, but please do speak up because we really want full participation in your contribution in the meeting, and also in kind of the synthesis and recommendations to come forward from it. So welcome, thanks for being here, and have a great day. Thank you.
Thank you, Bob. So I want to start by just an overview of how did we get here. Bob has done a really nice job talking about where we are integrating this concept within the projects that we're doing at NCI and beyond. But 26 years ago, that's 1993, Steve Shortell, who is a luminary in health services research, co-wrote an article in Health Forum that coined the term holographic organization. This really resonated with me because it describes a healthcare system so well integrated that, like a hologram, any part of the network would reflect the clinical fiscal aims of the system as a whole. Well, it's a really lofty, wonderful idea, but that's not the healthcare system that we're familiar with. I think a healthcare system that we're more familiar with is far more fragmented, and there are many, many silos. We're going to hear today about where healthcare has been over the past 20 years, and we'll try and pull this concept together. At NCI, as Bob said, we became interested in this topic maybe years ago when we were working with Steve Taplin, and he introduced us to the concept of multi-level research, and we developed this. We call it after the sociological model. Affectionately, it's the onion. It's Bronfenner's famous concept of a healthcare of an environment. And you see here, we've adapted it liberally. The healthcare organization sits somewhere between the community and houses the healthcare clinic, the physician, and the clinical team. And of course, since we're in a patient-driven environment, the patient is always at the center. I'd like to think of it that way as opposed to a hierarchy. So that's where we've been anchoring our thoughts. And I will just say that we have been, I don't know whether it's remiss or just a lack of knowledge in not including work in the healthcare system. But we are definitely working in that direction now with one of our large consortiums where we're looking at the healthcare organization, and we're trying to develop measures so that we understand more with the healthcare systems that we have decided something a little more concrete about where we're, how the healthcare system fits within cancer screening. So the workshop objectives are to explore the current state of the science of healthcare organizations, to review measures of organizational structure, behavior, interventions, and implementation strategies from a multi-level perspective. And lastly, to discuss the common problems in organizational science, measures, conducting and evaluating multi-level health and healthcare interventions. So I'm going to ask my colleague Paul Dario Rose to come up and to talk about the agenda we've crafted.
Good morning, everyone. I'd like to add my welcome to Erica's and Bob's, to all of you who are in the room, as well as to those who are joining by webinar today. The basic structure of our day today, start out this morning with several different talks to really, as Bob said, we're from a lot of different perspectives to make sure we're kind of all on the same page on some kind of basics of kind of the study of organizational research. We'll have some time for Q&A in the morning, but we're really going to kind of segue this afternoon. We'll have some panel discussions which will really allow us to delve deeper into some kind of practical examples of conducting this research in the real world. And then from there, we will have the opportunity to break out into small groups to dig even deeper into the topic areas that will be covered this morning. Just as far as we really want this to be, as both Bob and Erica have said, a chance for you all to help us think through how we can best promote research in this area. So again, there will be opportunities for you to speak up kind of during the sessions, ask questions, make your thoughts known in the breakout groups. We also have kind of a multimedia opportunity for there's an easel and Post-it notes in the back of the room. So if you have thoughts you want to jot down during the course of the day during the breaks, please do that. We will capture those as well as kind of the notes and that are coming from the spoken part of the meeting as well. And we do also have a email address if folks on the webinar would like to send comments or questions in as well. So please do take advantage of those opportunities as well. And so kind of getting us started with the talks for this morning, we can transition right into that. It's my pleasure to introduce Jose Escarce, who is a professor of medicine at the David Geffen School of Medicine at UCLA, as well as a professor of health policy and management in the UCLA Fielding School of Public Health, also representing the RAND Corporation today. And he's going to get us started this morning with a discussion of the landscape of healthcare systems in the U.S. So please join me in welcoming Dr. Escarce.
Thank you, and good morning to everyone. I'm really pleased to be here from Los Angeles. And I see my slides look different, where they changed to a... Oh, that's my introductory slide, okay. I mean, it's a much nicer background than I had. So if they change them all, that's fine. Sure, I'll do that. Perfect. Ah, there's my background. See, blue, no, nothing else. Anyway, so my charge is just to give in a few minutes a broad picture of the landscape of health systems in the United States. And so begin with the definition of health systems, why I think people think they're important. I'll talk briefly about what we know about health systems in the U.S. The truth is that although we've been talking about them and to some degree studying them for probably close to 3 decades, in terms of where they are, how many there are, how big they are, how much they have penetrated, if you will, not a whole lot has been known until recently. I think we know more now. And then I'll just summarize. So for the purposes of the work that we're doing at RAND, and RAND currently has a center of excellence that's been funded by AHRQ. They funded 3 throughout the country. The other 2 are at Dartmouth. And so we have, and Harvard, NBER, the National Bureau of Economic Research. And we sort of uniformly have adopted this definition. A health system is an organization that includes at least 1 hospital and at least 1 group of doctors that provides comprehensive and whose components are connected through common ownership, joint management. And so what's important about this definition is that we're talking about vertical integration, doctors and hospitals in particular. And so this excludes what have been around for longer, sort of so-called hospital systems, where a bunch of hospitals merge or they are bought by the same organization, and this would be, is what economists refer to as horizontal integration. So that's excluded here. An organization that's exclusively horizontally integrated wouldn't count. And it also excludes other type of vertically integrated arrangements, so hospitals and nursing homes, for example. So we're going to be referring to just hospitals and doctors. A lightning history of this is as follows. Really, horizontal integration in healthcare has been around for a long time, but it really began to pick up speed in the 1980s. So hospital systems really began to form for the first time. If you were around then, you probably saw a lot of news about organizations buying up hospitals and so forth. Multi-specialty groups grew and became more prominent. The creation of independent practice associations among smaller groups of doctors. And then vertical integration began and grew in the 1990s, so a little bit later. That movement really picked up a great deal of steam, and it progressed pretty quickly in the late 90s and early part of the preceding decade. Now, what's important to understand, I think, is that both of these types of integration were really a response to the introduction and the growth of price competition in healthcare. So before the 1980s, you know, there wasn't really price competition. And then health plans, and particularly managed care plans, began to be able to contract and to select networks of providers based on the basis of price. And so there's some really nice research from the era showing that in markets where the health has a lot of market power, the price is lower. And in markets where they didn't have a lot of market power, maybe there were more health plans and fewer providers, the prices were higher, sort of what an economist would have predicted. And so the way you fight the market power of health plans that are trying to bargain with you on prices is simply to get bigger and to try to develop, you know, some sort of a monopoly, if you can. And so that's really the main motivation for these integration efforts, and then of course you can say a lot of other things about them that cast them in a very positive light with regard to quality of care and efficiency and all those things, and whether those things are borne out, we can talk about later in the talk a little bit later. Health systems people think are important for two reasons. First, the fact that they've grown affects more and more providers, and affects how they practice, affects the relationships to the organizations in which they practice. I'll show you that in a second. And then, and also how patients receive care. And the other thing, of course, and that's probably what this meeting and most people, when they talk about this, is about, is, well, how has the growth of these vertically integrated systems affected how much we pay for health care, and then the quality of the care that patients get and the outcomes that they end up having. So this is a graph showing how these trends have affected, or at least trended with the way physicians practice. And so this is a simple graph that a lot of people talk about a great deal. And this is how many doctors own their practices. That was always the model of physician practice in the United States. A doctor would set up a practice or would join a practice, and then where the doctors were the owners of the practice. And the alternative model, of course, is for the doctors to be, well, a contractor, but that's a very small fraction, or an employee of an organization, simply an employee. And you can see that that's grown between 2012 and 2018. And what this doesn't show is the dramatic growth between, say, the 1990s, the mid-1990s, 2018. It would be much starker. And the reason this is important is because obviously employee doctors have very different relationships with the organizations in which they work than doctors who own their own practices. And this graph actually, there are a lot of doctors out there practicing already, but it's interesting to look at what's going on with new doctors and by gender. So if this is the data for 2018, and you can see that nearly 3/5 of women doctors were actually employees at that point, and about 2/5 of men. But the real stark difference is sort of the generational gaps. So if you look at doctors who are under the age of 40, so these are people who are out relatively recently, almost 70% of them are employees. Whereas among older doctors, that percentage is much lower. So what you can see is that, that these trends in the way that medical care or organizations are organized, the growth in vertically integrated systems, in large doctors' practices that employ doctors, et cetera, which are then often part of systems, has really changed this thing. And it's probably coincided with a trend among all doctors to want to have a more controllable lifestyle, that kind of thing. And so we have a situation now where more than 2/3 of young doctors are actually employees. Not surprisingly, these are data from the American Hospital Association annual survey, and it shows that the number of hospitals affiliated with health systems has grown a great deal between 2001 and 2017. And this is probably somewhat misleading because this question in the American Hospital Association survey does not distinguish between horizontal systems and vertical. And so there's separate questions that try to get at that, although this is not a great data set for trying to get at this issue. But in 2001, many of these hospitals were probably responding to the fact that they were in horizontally integrated hospital systems. But in any case, this has grown as well. So the growth of vertically integrated systems has affected doctors, has affected the settings in which they practice, the relationships they have with the organizations in which they practice, and obviously has affected hospitals as well. So why, what's the other reason why this is important? Well, because it can have effect on quality. And the good is probably pretty well known. So, you know, health systems can have more access to capital to pursue investments in improvement in quality and infrastructure, health information technology. They can have research departments, et cetera. In theory, at least, they have better communication and greater care coordination, so you reduce unnecessary testing, you reduce duplicative or redundant care, et cetera. You can have centralized leadership that facilitates a culture of continuous quality improvement and a culture sort of quality, if you will. You can more easily adopt care management systems and guidelines, and you can align incentives to standardize care. There's also a bad side to all of this, of course, and it sort of relates to what we talked about before. Power may result in higher prices, and we'll talk about the evidence on that a little bit later this morning. And it's something that people don't talk about very often, but market power will also reduce quality competition. So if you think that providers competing for quality is a good thing, then in fact the creation of big health systems may reduce the degree of quality competition in healthcare markets. Depending on how you pay for care and incentives to hospitalize patients to benefit system hospitals, and then also incentives just to increase utilization. So even if you were to believe the things on the previous slide, there may be a downside to all of this. And what that means is that these issues really remain largely an empirical question. And I'll talk a little bit about the empirical research, and I'll just say that there's an awful lot more that could be done and probably ought to be done. So let me just give you a bit about the landscape. So one of the big efforts in this was the AHRQ, the ARC compendium that they have just published a paper on this year, but released a couple of years ago. And so what they found is that there were 626 systems in the United States with more than 50 doctors. And when they tried to figure out, well, how many doctors and how many hospitals were involved in these systems, they got that same percentage more or less that the AHA got, except this is just vertically integrated systems now. So about 70% of hospitals they think are involved in these things, and about 44% of doctors and about 43% of primary care doctors. So the penetration is quite extensive. They also tried to look at this geographically, and interestingly, this is sort of what they view as the penetration measured as the number of hospital beds belonging to health systems by state. And the lightest colors are the lowest penetration, sort of the lowest quartile, and the darkest blue is the highest quartile. And you can see that there's some states over on the west that have high penetrations, and then some in the east, Florida, Michigan, and so forth. So that's one effort to give you a lay of the landscape. The second effort comes from us at RAND. And so we've taken a completely different approach. We used completely different types of data. And we counted, instead of 626, we counted 477 groups with more than 50 doctors, although I will say our data source is Medicare, and so probably Medicare mainly. So we probably are undercounting doctors. There probably are, because Medicare data don't include pediatricians, and they sort of underrepresent obstetricians and gynecologists and so forth. But in any case, we came up with similar numbers, actually. So we have about 43% of all doctors participating in systems, about 38% of primary care doctors, and about 45% of non-primary care doctors. So again, the penetration among doctors is substantial. And we tried to do an analysis of penetration. We measured it a little bit differently, using the percentage of traditional or fee-for-service Medicare beneficiaries that are taken care of within health systems. And we did it by hospital service area. And this is the map that we get. So you can see, again, the darker blue is the highest penetration, and it runs from 75% to 100%. And the light blue is the lowest penetration. We didn't find any beneficiaries in health systems in those gray areas that are kind of scattered all over the place. You can see that it's not completely the same as the ARC map, but it overlaps to some degree. And of course, they're measuring something quite different from what we're measuring. So just to summarize, vertically integrated health systems have grown over the past 25 years, and currently nearly a half of doctors and 2/3 of hospitals take part in these. There is a great deal of geographic variation in the market penetration of these systems. They have contributed to changing the nature of medical practice, and they almost certainly have effects on quality of care, but that's an empirical question about which we still need to learn a lot more.